Bismillahirrahmanirrahim. We will be discussing the thyroid cancer with perspective to radiation oncologist today. I come from INMOL. INMOL is the biggest organization of Pakistan Atomic Energy Commission. Atomic Energy Commission is running 18 such cancer hospitals in Pakistan, and INMOL is equipped with a PET scan, with 3 linear accelerators, leukemia-based PET CT scan, and so on. And about 80 to 85% of cancer patients in Pakistan are being treated at these 18 cancer hospitals being run by Pakistan Atomic Energy Commission. As far as the incidence of thyroid cancer is concerned, approximately 65,000 new cancer patients are diagnosed each year suffering from thyroid malignancies. And the majority of these patients have got excellent prognosis. Most of them are curable, whereas those who present in stage 4 with metastatic disease have got about 50% 5-year survival. The finding of a nodule in thyroid gland is not uncommon. These are called incidentallomas, which are silent and asymptomatic. And in an autopsy study, it was seen that about 12% of the thyroid glands contained one thyroid nodule, and about 37% contained uh, multiple nodules. As far as the studies in living patients are concerned, using a thyroid sonogram, it was seen that about 22% of the thyroid gland contains solitary nodules, and about 45% contained asymptomatic multiple thyroid nodules. As far as the risk factors or predisposing factors for thyroid malignancy are concerned, it is seen that if one first degree relative is suffering from thyroid cancer, the chances of getting CA thyroid are more. Similarly, those patients who have got the history of exposure to external beam radiotherapy have got increased chance of developing thyroid cancer. If you have got prior cytologic diagnosis of CA thyroid, then again it is at increased risk. Male sex is at increased risk. Focal uptake of FDG in a PET scan has got increased risk of thyroid cancer. Similarly, men too and have got more chances of medullary thyroid cancer. Serum calcitonin level of more than 50 to 100 has got again increased risk of thyroid cancer, and residing near a nuclear reactor accident again increases your chances of suffering from thyroid cancer. As far as the ATA, the American Thyroid Association recommendations and guidelines are concerned, we'll be discussing them one by one. The routine measurement of thyroglobulin for initial evaluation of nodules is not recommended, but the panel remained silent about the measurement of serum calcitonin levels in patients with thyroid nodules. As far as the thyroid sonography is concerned, all the patients who have got suspected thyroid nodules should get a thyroid sonogram done. The panel recommends that Bethesda system should be used for evaluating the FNA cytology of thyroid nodules. As far as FDG PET scan is concerned, it is recommended that those patients who have got focal uptake, they have got an increased risk of thyroid cancer, and FNA is recommended in nodules more than 1 centimeter on a PET scan with focal uptake. But those patients who have got diffuse uptake or lymphocytic thyroiditis do not require further evaluation of nodules. Then there are some gene mutations or oncogenic alterations like RET, PTC, BRAF, and RAS mutations, and these increase the risk of developing thyroid cancer many folds. If we see the Bethesda category 2, 3, and 4, the positive mutations, they increase the risk in different categories of 88 to 95% of developing thyroid cancers. And all these patients who have got positive gene mutations, they should be treated with total thyroidectomy. And with negative mutations, you can offer them some conservative approaches. There are some commercially available brands for these gene mutations, and Afirma is one of them, which has got the sensitivity of 92% and negative predictive value of about 93%. As far as the ATA recommendations for surgery is concerned, it is said that when surgery is considered for a patient with solitary, cytologically indeterminate nodule, thyroid lobectomy is the recommended initial surgical approach. And this approach may be modified based on clinical, sonographic characteristics or patient's preference or molecular testing when performed. For patients who have got high risk tumors, total thyroidectomy should be performed, and those patients who have got low or medium risk tumors, thyroid lobectomy can be offered. Uh, because total thyroidectomy should be preferred in those patients who have got indeterminate nodules with cytologically suspicious malignant uh, outcome. And for those patients who have got known mutations, they should also be treated with total thyroidectomy. And those tumors which are more than 4 centimeters should also be treated with total thyroidectomy. As far as the description of pathology report is concerned, the ATA suggests that TNM criteria should be used, and the report should contain all these following features like vascular invasion, number of vessels, number of nodes examined and those involved, size of the largest metastatic nodal focus, extranodal extension. The variants with favorable and unfavorable histologies should also be described, and the variants with familial syndromes should also be mentioned. As far as the risk stratification is concerned, the low risk tumors are those which have got no local or distant mets. All microscopic tumor is resected. There is no locoregional tumor invasion, no aggressive histology or vascular invasion. And if I131 is given, there is no uptake outside the thyroid bed. The intermediate risk cancers are those who have got positive microscopic parathyroid invasion, which have got positive lymph nodes or uptake outside the thyroid bed, and which have got aggressive histology and vascular invasions. The high risk tumors are those which have got macroscopic invasion of the tumor, incomplete tumor resection, and distant mets or thyroglobulin suggestive of distant mets. Then there is a decision of I131 ablation, whom to ablate and whom not to ablate. So it is generally recommended in the ATA guidelines that for low risk differentiated thyroid cancer, ablation is not required. And for those cancers which are unifocal or multifocal micropapillary thyroid cancers, they again do not require radioactive iodine. Uh, for intermediate risk, yes, I131 ablation should be given, and this should be in selected patients with 1 to 4 centimeter tumors, which is a gray area, and some of them which have got high risk features, combining the age, tumor size, nodal status, histology, and so on. For high risk cancers, ablation is mandatory, which have got known distant mets, which have got extrathyroidal extension regardless of tumor size, and all the tumors which are more than 4 centimeter. Even if there are no other high risk features, they should get I131 treatment. As far as the dose is concerned, it is said that if radioactive iodine ablation is performed after total thyroidectomy, in low risk tumors or intermediate risk tumors, a 30 millicurie OPD based dose can be suggested. And for those cancers which have got suspected microscopic residual disease, 150 millicurie dose, of course, which needs admission for 2 to 3 days in a hospital in an isolation room, should be recommended. And it is uncertain whether doses of more than 150 are really beneficial. A post-therapy scan again is a recommendation by the ATA guidelines to see the disease staging and document the activity in the thyroid bed area. As far as the follow-up is concerned, high-risk patients should be followed every 6 to 12 months with thyroglobulin, and low-risk patients for 6 to 18 months with thyroglobulin, and TSH levels should be kept below 0.2 nanogram per milliliter. This is the graphic representation for low risk tumors, the TSH level should be kept between 0.5 to 2. For high-risk patient, it is between zero point 0.1 to zero point 0.5. And if the patient has got persistent disease, the TSH levels should be kept below 0.1. Then there are some patients which become iodine refractory. That is, they no longer respond to radioactive iodine, and these cancers are defined like the malignant or metastatic tissue does not ever concentrate radioactive iodine, or the tumor tissue loses the ability to concentrate iodine. Previously, it was concentrating, and now it is not. Then the iodine is concentrated in some lesions but not in other lesions. And then metastatic disease progresses despite significant concentration of radioactive iodine. When a patient with differentiated thyroid cancer is classified as refractory to iodine, then there is no indication for further I-131 treatment. Those patients who become refractory to radioactive iodine, what options we have got? Either you can just follow them up, monitor them, give symptomatic treatment, or you can give lesion directed therapy like surgery, external beam radiotherapy, or thermal ablation, or you can put them in clinical trials, or now we have got the option of TKIs, the systemic targeted therapy, which can be effective in these patients. This was the trial initially which showed the advantage of giving TKIs, the tyrosine kinase inhibitor lenvatinib, to a CA thyroid patient when compared to placebo, and there was a very good survival advantage in these patients who were put on lenvatinib. Keeping the current treatments options in mind, it is seen that in stage 1, you can cure about 100% of the patients. Even in stage 2 and stage 3, up to 82 to 98% patients can be cured. And in stage 4 disease, the survival is like 38%. This is a small data from INMOL, what we have been seeing in our patients. We generally see about 100 patients per year. We register like 6,000 to 7,000 new cancer patients each year. And as far as the CA thyroid is concerned, we receive like 100 or 100 plus patients each year. Most of them are female. Most of them are between 20 to 50 years of age. Histopathology generally is papillary CA thyroid. We have got some follicular cancers also, medullary, anaplastic, and so on. They are generally multinodular, and size of nodule is generally in the gray area, which is 1 to 4 centimeter. And the doses of radioactive iodine are generally high, but now we are gradually shifting to low dosage as far as the new guidelines are coming up. Most of them come with total thyroidectomy, and some of them we have to refer for total thyroidectomy. And up to 30 millicurie, we don't admit the patients, but for more than that, we have to admit the patients for 2 to 3 days generally. So we can summarize that we don't need biopsy for every nodule which is less than 1 centimeter. Lobectomy is a reasonable option, which is coming up quickly. More detailed pathology reports should be prepared. Use of selective radioiodine is important. Not all the patients should be ablated. We should very cautiously select those patients who should be given iodine. And then we should also see which are the patients who require low dose on OPD basis, and which are the patients who should be admitted for higher dosages. Cross-sectional imaging for high-risk disease should be performed. ATA recurrence risk and response to therapy should be done according to TNM AJCC recommendations. And then radioactive iodine refractory patients can be put on clinical trials, or they can be offered TKIs. Thank you very much. Thanks a lot.